tunnel this area very carefully, because you have a drainage here, you have a fistula, and the fistula is basically a hole in the bone in terms of either fenestration, you have a little window there, or you have adhesins that it's creating that gingival reaction. So have in mind that whenever you're using a technique that is minimally invasive, that has a limited access, especially visual access to the surgical site, you need to be very efficient in terms of seeing, because you need to see, you need to watch, you need to detect how far does that bone defect goes in order to be able to regenerate and isolate as better as possible. And you have seen in other previous slides that I really support that whenever you have a limited access, or you feel that you have a limited access, by using minimally invasive techniques, you're going to need to raise a flap and see exactly how far that defect goes and how far that dehiscence of the bone goes in order to be able to deflect the flap, separate it from the problem, and then regenerate, isolating properly with the membrane. So what I'm going to do is, by tunneling that gingival margin located at the located at the number 23, and also the gingival margin located at the number 24, I'm going to displace coronally. Going beyond the mucogingival junction, I'm going to be able to displace and coronally advance that flap and cover those recessions. So I'm going to do two things. I'm going to extract a tooth that has a problem. I'm going to place an implant. I'm going to put a crown on the top of that implant. Obviously, I need a specific primary stability to warranty the stability of my implant during the whole osseointegration process. And then I'm going to mobilize the same day that gingival tissues to the coronal aspect, and then I'm going to use a connective tissue graft that I'm going to place it right on the top of my canine and also on the top of my premolar. That connective tissue will not only serve as a resistant tissue to the relapse, and also to occupy a volume to give extra volume to your surgical site, but also is going to cover that drainage out that will help the soft tissues to close and isolate the problem from the inside, from the outside. Because at some point, right now you have a problem inside, but whenever I extract this tooth and I place my implant, I'm going to create a very clean area to receive my implant, my bone graft, and then my underlying soft tissue that is going to isolate the clean area from the dirty area which is outside. So the connective tissue graft will also be used to separate and to isolate the problem and reinforce and heal and help to heal the wound created by the fistula. So this is what this slide is the one that I always show to everyone. And I love Dennis Tarnow, one of my mentors, and Steve Chu for providing this paper. And this paper shows, please, whenever you're going to do an immediate extraction implant placement,